welcome everybody. I have the pleasure to introduce today Professor Robert Porte, who is a prominent liver transplant surgeon from Groningen, the Netherlands. He is actually from Rotterdam. He did his medical school in Rotterdam, the Netherlands, then his residency in Leiden, and then he moved to Groningen to start working as a hepatobiliary surgeon. He also was trained in the US for a couple of years. He did a liver transplant fellowship at Duke University. And then he moved back to Groningen, and since 2008 he's the chief of the hepatobiliary and pancreatic surgery and liver transplantation department in the University of Groningen. His main interests are, some of them, the most important ones are the liver coagulation disorders in liver diseases. He's an expert on that field, but he's not going to talk today about that. He's going to talk about machine perfusion. He's a prominent investigator in this field. It's a hot topic recently in liver transplantation. And his interest in this field came from his interest in evaluating one of the most, as many people know here, prominent and frequent complication after liver transplantation, which is the biliary complications. His initial interest evaluating this made the move to the use of this type of ex situ preservation in order to improve the quality of the livers to be transplanted and to decrease the rate of this dreadful complication. So we are keen to listen to your talk, to learn from you. Thank you very much for coming, Robert, to spend the whole day with us. And after that, we will have with our colleagues in Madrid and the audience here some time to make questions and to ask you about our doubts and questions that we may have after your talk. Thank you very much for coming.
Well, thank you so much, Tino, for your kind introduction, and Jordi for giving me an enjoyable day here. It definitely was. It's a pleasure and honor for me to be here in Barcelona. Not the first time in the city, but the first time really in the Hôpital Clinique. So yeah, I had two choices to talk about hemostasis and coagulation issues in liver disease, which is one of my research interests, and the second one is more focusing on bile duct complications and trying to avoid this with machine perfusion. So I decided, since machine perfusion from a surgical perspective is very rapidly evolving and entering the clinical practice, to talk on this. But I'll be happy to discuss afterwards coagulation issues as well, if there's any questions. Well, this is my disclosure. I have no financial link with any commercial company. To talk about machine perfusion, I think it's important to first identify what are the reasons why people started using machine perfusion increasingly in liver transplantation, where the results over the last 40 years have been reasonably good, to actually very good, if you talk about regular liver transplantations with 80 to 90% patient and graft survival. But we have discovered over the years that it's not good enough for the regular preservation method in a box with ice. It's not good enough for extended criteria donor livers from either donation after circulatory death donors, so DCD livers or fatty livers or all the livers, and there the results are suboptimal. In our country last year, of all donors in the entire country, 60% were DCD donors. That has been increasing over the years, and we have noticed a substantial morbidity that comes from livers but also kidneys that are transplanted from these donors. So that was actually the main reason for us to embark on machine perfusion. First of all, to improve outcome for ECD, DCD liver transplantation, reducing primary non-function, reducing the rate of biliary complications, but also, and we are moving to that now, increasing the number of transplantable organs. For example, in my country, it's a rather small country, the Netherlands. We have only 15 million people, and we have about average 250, 260 donors per year in the entire country. We're one of the lowest donation rates. I think it's about 1/3 of the donation rate in this country, but you guys are world champions, so there's no surprise that we're lower. But so 250 donors per year, and of course every donor has a liver, but still we only, on average, we're transplanting 150, 160 livers per year in the entire country. So basically 90 livers without getting more donors should have been or could be accessed more carefully than just on paper if it comes to the donor data to see if that liver will be transplantable. And I think there is room for improvement and for increasing the numbers of transplantable livers that have an acceptable outcome after transplantation. So those are the two incentives for machine perfusion. Coming back to improving outcome, this center is known for the excellent results also after DCD transplantation, and we already spoke about this earlier today, that with the introduction of normothermic regional perfusion in DCD donors, the incidence of biliary complications or post-transplant cholangiopathy has come down significantly. But still, I think there is many centers in the world that are struggling with these complications. It's actually a spectrum of disease. It's not only strictures, but it's also intrahepatic leakage, biloma formation, which may be due to completely necrotic bile ducts that we are transplanting, or intraductal cast formation, which is probably sloughing off of epithelium in the bile duct lumen, forming a nidus for cast formation inside the lumen of the bile duct, obstructing, of course, its bile flow. That's all in the spectrum of this entity of post-transplant cholangiopathy. And we know that the incidence of this type of complications after DCD transplantation is about 2 to 3 times higher than after DBD transplantation. And there's no uniform definition in the literature. There's no uniform follow-up after transplantation with respect to the bile duct. So centers have been reporting various numbers, but I think roughly it's about 3 times higher. It's also confusing that there's different names in literature. Some people call it ischemic type biliary lesions. That was, I think, the old name. Then for some years, people have been calling it non-anastomotic strictures, which I think is more a general name, acknowledging the fact that you don't really know the exact pathogenesis. Now people also call it ischemic cholangiopathie. I think, personally, I think post-transplant cholangiopathie, to group the whole spectrum, is a more neutral term. So I prefer to use the term post-transplant cholangiopathie. So what do we know about the pathogenesis? I think it stands out that ischemia and ischemia reperfusion injury is a key event in the development of biliary complications. But there's also increasing evidence that the immune system, either secondary to the ischemia reperfusion injury or directly, may have an effect, especially in biliary strictures that develop more late after transplantation. For example, in patients that are originally transplanted for PSC or autoimmune hepatitis that are more prone to develop biliary strictures, and you might call it recurrent PSC. Some people group it still as ITBL or NAS. There's substantial evidence that bile salt toxicity contributes to biliary epithelial cell injury during preservation. I'll come back to that in the rest of my talk. There's now increasing evidence that also lack of regeneration of the biliary epithelium, or even the whole bile duct wall itself, contributes to the risk of developing these biliary complications. And also I come back to that in the rest of my talk. And as probably is the case in almost everything in nature and in medicine, it's probably a combination of all of these effects. Now, what about the degree of injury in a regular transplant? We were trying to look, for many years we were taking biopsies at the time of liver transplantation, not only from the liver parenchyma, from the graft, but also from the bile ducts, to look at gene expression and bile transporters, etc. And we had a very hard time in getting a good PCR signal from the bile ducts. And we thought, especially if it comes to cholangiocyte-specific proteins and genes. So we initially couldn't understand this. And then we actually did a large database, a large analysis, looking at the bile duct biopsies that we took at the time of transplantation under a microscope. And we discovered that many of those bile ducts are actually severely injured. Now, you could argue this is the distal stump of the cut bile duct, that it might be surgical injury, but even if you would take livers that have not been transplanted and are available for research, and you take biopsies from the biliary tree higher up, even in a regular DBD graft, there is substantial injury of the bile duct. So the bile ducts, we know, especially the cholangiocytes, are very susceptible to ischemia, more than hepatocytes and endothelial cells. They slough off easily from the basement membrane, and more than 90% of the livers that we are transplanting on a daily basis, if you would carefully look for histological evidence of injury of the larger bile duct, so intrahepatic or extrahepatic larger bile ducts, there is evidence of injury. So it's actually a surprise if you think that it's the amount of injury that dictates whether or not that liver is going to develop post-transplant cholangiopathy, that not more livers than just the 10-12% in DBD and maybe 20% in DCD liver transplantation develop post-transplant cholangiopathy because so many have injured bile ducts. And we have seen livers that basically have bile duct scaffolds, so the epithelium is completely gone. And we basically then sometimes, especially in the DCD population, transplanting livers that have kind of a non-epithelialized bile ducts and yet do not develop biliary complications. So that actually led to the suggestion that it's not so much the degree of initial injury, but more the lack of sufficient and timely regeneration of the bile ducts that contribute to the development of these strictures. Now, one important aspect is if you look more carefully into a bile duct, there is different components, histological components, that contribute to the entire wall of the bile duct, especially the vasculature, which we call the peribiliary vasculature, the small arteries that run into the bile duct wall, but also the peribiliary glands, which have been seen by pathologists for many, many years, but basically ignored as, well, they're probably mucus producing or local hormone producing glands in the bile duct wall. And we now know that those PBG, the peribiliary glands, are connected to the lumen of the bile duct via very small canals and actually a niche of stem cells. So the peribiliary glands we now see as the reservoir of pluripotent stem cells where the larger bile ducts can regenerate from. Very similar to the canals of Herring that we know are present in the oval cells that are present intrahepatically, which is a reservoir for pluripotent stem cells, or at least bipotent stem cells. There is substantial amount of evidence that the peribiliary glands contain pluripotent stem cells in the biliary tree, in the larger bile ducts. And if those two structures are damaged histologically, so even though the epithelium is not predicting the development of post-transplant cholangiopathy, if the PBG or the perivascular plexus is severely injured, those are the livers that, in this study at least, developed post-transplant cholangiopathy. And this was a 128 population study, combined material from our center in Groningen with the Mass General Group in Boston. So what are those PBGs? Well, the PBG, as I mentioned, are some kind of a gland-like structures situated either deep or subluminal in the bile duct wall. As I said, they are connected to each other, but they're also connected to the lumen of the luminal epithelium of the bile duct wall, as you can see here in this cartoon, but also in the histological slide. And it's especially the deep ones that contain the most stem cells, and if those are injured, so the more extraluminal deep PBG, if those are injured, that's a very strong predictor of developing biliary complications. So that should be a potential target to preserve and even stimulate regeneration after transplantation of the bile duct. And they are basically everywhere. So if you would see a graph of the biliary tree like you see here, up to the intralobular ducts, the smaller ducts, all of these larger ducts contain either subluminal or extra or deep PBG. But they are most prominent actually in the larger bile ducts, either intra or extrahepatic. And in a collaborative study with the group in Rome, we have recently published in Hepatology that if you would take bile ducts from discarded livers that are offered for research to us and not transplantable, and we slice those bile ducts, bring them in culture, you can keep them up to a week in a tissue culture environment. And so it's a whole bile duct slice, and then you see a similar process, what is probably happening in vivo. You see the beginning of regeneration. You see that the PBG are actually very resistant to ischemia reperfusion injury. They are not damaged to a certain extent to the same extent that the epithelial lining is damaged. And then the very primitive stem cells that are present in the PBG start maturing, start migrating along the canal, start moving towards the lumen of the bile duct, and then starts regenerating a normal epithelial lining. So that study is an in vitro, ex vivo demonstration that indeed from the PBG there is maturation and migration and proliferation of stem cells to restore regular biliary epithelium. So how could we, knowing this, how could we prevent? Well, of course, if we can cut down on the ischemia as much as we can, and NRP, for example, is a very good method apparently to cut down on the early ischemic injury after a DCD procedure. But also, if we cut down on cold ischemia or are able to generate and to enhance protective mechanisms against bile salt toxicity that could help us to prevent post-transplant cholangiopathy. The bile salts, I think, is very interesting because bile salts, we all know, are detergents. They are produced by the liver to digest lipids in our meal, in our guts. So they solubilize lipid membranes. They tend to do that, and the bile ducts themselves are protecting themselves against, the cholangiocytes are protecting themselves against the detergent effect and the toxic effect of bile salts. First of all, bile salts are captured in my cells, of course, with cholesterol and lipids in the bile. But even if they would diffuse into a cell, that process is blocked by making bile alkalotic. That's called the bicarbonate umbrella. So cholangiocytes are secreting bicarbonate via A2 receptor and a CFTR, the cystic fibrosis transporter, in the membrane, the luminal membrane of cholangiocytes, secreting cholangiocytes, making bile alkalotic and protecting themselves. So you could say that alkalotic, the pH of bile is a way for cholangiocytes only to basically to protect themselves against the detergent effect, but it could also be used as a viability marker, as we are doing now for machine perfusion. I'll come back to that later in my presentation. So those are protective mechanisms. What about stimulation of regeneration? If you could do that either before the transplant or early after the transplant, that could also be an alternative to avoid and to reduce the incidence of complications. And I think overall, all of these could be achieved with oxygenated machine perfusion. So that's how we got our interest in machine perfusion, either in vivo, as you can do in NRP, or ex situ, as we do now in end-ischemic machine perfusion. Oxygen here is the key, independent from the temperature, I think, but it helps us to preserve those livers better, and especially the bile ducts. Now, there is, for those of you working in this field or from the surgical group, I think you know the literature. There's also confusing about nomenclature, etc., about how people define subnormothermic, normothermic, hypothermic. In general, now we in a recent consensus meeting have decided that anything below 12 degrees is called hypothermic, which is now most frequently used in clinical practice, or normothermic above 35. So that is based also on the reduction of cell metabolism based on the reduction in temperature. And basically normothermic and hypothermic are the most frequently used now types of machine perfusion in clinical liver transplantation practice. Now, if you talk about organ preservation in the time between donation and transplantation, if you put it in a cartoon with a time scale, of course, this is what we have traditionally done, what's good enough for high quality, good organs. Cold flush out in a donor, cold storage, cold transportation, and then during implantation, maintain cold ischemic preservation of the liver until you revascularize it and hook it up to the recipient. One step forward could be that you perfuse the organ before the transplant in the transplant center. That is being explored mainly by Guerrera in New York, who was one of the pioneering groups to do that, either oxygenated or not actively oxygenated. I think there's now increasing evidence that oxygen, even at low temperatures, is very beneficial. I'll come back to that in a minute. Or try to rewarm the organ already a little bit before implantation to avoid any secondary damage from rapid changes in temperature. We call that controlled oxygenated rewarming. Or normothermic machine perfusion. You could argue that basically that's replacing in vivo perfusion. So I personally have been wondering what could be the benefit of this. The only benefit I could think of is that you can actually assess the function of the liver before you implant it to avoid or try to avoid primary non-function. Assuming that if the liver would be functional on the pump, it would also be functional 5 minutes later or 10 minutes later in the recipient. But other than that, a reconditioning effect, it's still debated where you are truly reconditioning a liver with normothermic machine perfusion. I think what does help if you can cut down significantly on the cold ischemic preservation time by starting machine perfusion already in the donor hospital. This center has also been participating in the COPE trial that was led by the group in Oxford by Peter Friend, and I come back to that in a minute as well. Or normothermic regional perfusion, especially in DCD donors, where you restart the circulation after withdrawal of life support, after the patient has been declared death based on lack of circulation by the treating physician, and then you quickly cannulate and reintroduce perfusion regionally in the abdomen to avoid ischemia and to basically let organs recover from that initial insult. You could either continue perfusion then. I've been to Guangzhou in China, where there's a group now combining machine perfusion in a donor hospital, transporting the organ while being perfused to the transplant center, and then hooking it up to a patient without even interrupting blood supply. They call it ischemia-free liver transplantation. Very impressive data, very impressive to see how they do this. Technically very challenging at the same time. So there's different modalities that have been explored and are currently still explored by several centers in Europe. There's also different companies that have evolved. There's now 4 devices available, I think, on the market that are commercially and CE marked, commercially available, either in Europe or in the United States. The first one from ORS, from Organ Recovery System, can only hypothermically perfuse and is not actively oxygenating the perfusion fluid. I think that already is now old-fashioned, and there's now, as I said, substantial evidence that even at low temperatures, adding oxygen actively to your perfusion fluid is beneficial. The Groningen group, I was not involved in this, but the Groningen group, a few engineers have developed the Liver Assist, now a spin-off company from the university called Organ Assist, that is versatile, so either hypothermic or subnormothermic or normothermic, depending on what you as an operator decide, can be used for liver perfusion. And then there's 2 more fully automated normothermic machines that are also transportable, the OrganOx and the TransMedics device from the US. So to summarize, what is the current insight on the benefits of hypothermic versus normothermic? As I mentioned already, initially I didn't believe in hypothermic machine perfusion. I thought, well, if you really want to resuscitate an organ, you need to warm it up to 37 degrees, metabolism will start running again, and then an organ will need oxygen, so then you need to actively add oxygen. There's a group in Zurich from Dukowski and Glavien that have been advocating hypothermic oxygenated machine perfusion for a long time, and they say that that's really resuscitating the mitochondria. And initially we couldn't believe this, but we have actually replicated that data. What happens if you give a liver oxygen at 4 degrees? The hepatocytes and the cholangiocytes and endothelial cells not so much get active again, and they don't, but the mitochondria apparently can very well handle oxygen at low temperature. They start regenerating ATP again, which is almost absent after DCD, withdrawal of life support, and agonal phase. So all those DCD grafts, either kidney or liver, are ATP depleted upon arrival if you don't treat them. But if you give them oxygen and perfuse them at low temperature, they restore their ATP. And as a consequence of that, the mitochondria are resuscitated. In fact, oxygen consumption after their oxygen depth has been restored goes down to almost 0. They enter some kind of a hibernation state. And then after reperfusion, the free radical production, which is normally present upon normothermic reperfusion in the recipient, the free oxygen-free radical production is dramatically reduced. So that's probably the underlying mechanism why hypothermic oxygenated machine perfusion is beneficial. The advantage for us as surgeons, it's very simple. You still maintain low temperature. If there's a technical pump failure or whatever, you don't run into trouble that the liver is warm and ischemic, so you don't need an oxygen carrier. You can just use a regular perfusion fluid that's very similar to the static cold storage perfusion fluid that we use, but you need to oxygenate it. And so far there's been no evidence for oxygen-induced damage, so you cannot over-oxygenate a liver at low temperature. Now, normothermic obviously makes the liver metabolically active. You can potentially assess its function and viability. It gives you room for interventions. You could potentially, with hormones or drugs or stem cells, try to repair an organ. But it's also potentially riskier. If something goes wrong, if there's a pump failure or a technical issue, the liver's at 37 degrees and might run into ischemic complications if that is too long. And it's definitely more expensive. And you need an oxygen carrier. Once you increase the temperature, the amount of oxygen you can dissolve in a watery fluid is much lower. That's of course why we have erythrocytes in our blood. You need to hold the oxygen at 37 degrees in the fluid. The organ also needs more oxygen, so you need to bring more oxygen to the organ. So that's why you need an oxygen carrier, probably above 20 degrees. If you start warming up an organ above 20 degrees, you need an oxygen carrier in that perfusion fluid. This is our first clinical study with hypothermic machine perfusion, where we perfused the liver before implantation, both via the hepatic artery and the portal vein with just regular cold perfusion fluid. And you see after, we call that DHOPE, the dual hypothermic oxygenated machine perfusion. If you take a biopsy of the liver before a machine perfusion, so after arrival in the transplant center, after it's been ischemic for like 6-7 hours, their ATP is gone, their ATP depleted. If you keep them on the pump for an hour, usually 2 hours, we keep it on the pump, it will completely restore its ATP. It goes up like tenfold. And then if you reperfuse and implant that liver in the recipient, as I said, you have significantly less ROS production, less IR injury. And of course, ATP then starts being consumed because metabolism comes back in and ATP drops a little bit. So basically, it's like having a cell phone with a dead battery. You want to make a cell phone, you want to look up something on the internet, and then you're charging your phone, and at the same time you're calling, your battery is not charged very rapidly, right? Because you're draining it at the same time you're charging it. But that's what we do on a daily basis with livers and kidneys. They come in with ATP depleted, we hook it up to the patient, it needs to function immediately, but it also needs to restore its battery. Whereas if you would just let it sit in and plug it in first and let it restore its ATP, of course, then it's much easier and much better to use it. So basically that's how I use them as a metaphor to understand what's going on with a hypothermic oxygenated machine perfusion. And the results have been, at least in our hands, very favorable. If you look at compared it with historical controls group, there was the pilot study in 10 patients, DCD grafts, regular DCD grafts that we put on the pump for 2 hours with hypothermic oxygenated perfusion before we transplanted them. Compared it with historical outcome data, patient graft survival, it was all significantly better. And also, we have not retransplanted any of those livers for ischemic cholangiopathy, whereas in the past, we had almost 25% significant biliary complications, at least in the Netherlands, in all 3 centers. So this is just a pilot study in 10 patients, but it was favorable enough to start a randomized controlled trial. To confirm the clinical observation, we also, again, took biopsies from the bile ducts at the time of transplantation, either before reperfusion, so at the end of cold storage and after reperfusion. And very similar to what we had shown in the JHEP paper several years earlier, the biliary epithelium basically is gone. There is significant injury of the bile ducts. The PBGs are relatively spared. But after reperfusion, with all the ROS production and the reperfusion injury, that's where the injury occurs. PBGs are severely injured, so those are the livers that are at risk for developing biliary complications. Whereas if you treat that liver with DHOPE first, yes, the biliary epithelial lining is still gone. It doesn't regenerate, of course, in the cold and in a short period of time, but at least you prevent the second hit of reperfusion injury, especially to the BBG, as you can see in this histological study after reperfusion. So is that good enough to prevent post-transplant cholangiopathy? We don't know. But we're now facing 3 randomized controlled trials that are ongoing in Europe. One is led by the Zurich group. It's called the HOPE DBD multicenter trial, led by Philip Dukowski in Zurich. The primary endpoint is their overall complications after transplantation. We have initiated a DCD trial. We use dual perfusion. It takes a bit too much to dwell on the benefits and maybe disadvantages of combined dual perfusion versus single, but probably single portal vein perfusion is good enough as well. And we have the primary endpoint on biliary strictures. It's a study for the Dutch centers, Belgium centers, and 2 centers in the UK. We're almost done. We needed 156 patients, and we're now at 130 or so. So hopefully we'll have the results, and then of course we need 6 months of follow-up. Every patient gets an MRCP 6 months after the transplant. We'll be able to tell if that is going to reduce the incidence of biliary strictures. And then there's a study led by the Aachen group in Germany, very similar to the HOPE protocol, I think, in ECD livers. So that's the story, I think, so far that we know on hypothermic oxygenated machine perfusion. What about normothermic machine perfusion? I mentioned already, you could theoretically start it in a donor and then continue normothermic machine perfusion until you are in the recipient. We call that normothermic machine preservation. You can also use it anti-ischemic after static cold storage. So leave everything as it is, the whole procurement, the transportation in a box with ice, and then wait until you have arrived in the transplant center where you do the machine perfusion. Or as the Chinese people are now exploring in Guangzhou with ischemia-free transplantation, where you basically don't interrupt blood circulation to the liver at all during the whole transplant process. Now, normothermic machine preservation, so from donor to recipient, has been, as I mentioned already, exploring by Mr. Friends, Dr. Peter Friends' group in Oxford. There's a recent European multi-center trial that was completed and published in Nature this year or last year. The endpoint, you can argue whether that's any clinically relevant. The primary endpoint was a decrease in serum ALT in the recipient after transplantation. That endpoint was reached. So from that perspective, you can say it was a positive trial. But if you look at the overall patient graft survival, incidence of complications, there was no significant difference. Now, you could argue that that means that for a regular graft, you don't need anything fancy and expensive like this. Or you can say, well, apparently it's not good enough for some livers. For example, the DCD grafts, there was, if you look at post-transplant cholangiopathy, the subgroup of DCD grafts versus DBD grafts in this trial didn't show statistically significant reduction. There was a numeric reduction in the DCD grafts that could have been significant, of course, with larger numbers, but even in this, I think, 200-plus trial, they didn't show a significant reduction, statistically significant reduction in biliary complications. In fact, there was one liver retransplanted for post-transplant cholangiopathy in both groups. So I think here we have no convincing evidence at the moment in the current literature that normothermic machine preservation is really reducing the number of biliary complications. But I'm sure they're going to do more sub-analysis in the DCD population in this trial. Now, if you talk about antischemic, so not normothermic machine preservation, but antischemic normothermic machine perfusion, that has been actively researched by the group in Cambridge, but also in Birmingham in the UK, especially in high-risk DCD grafts, Chris Watson's group. This is a recent publication from this group in a relatively small number of patients, 12 versus 24 historical controls, very similar with respect to donor demographics, called ischemia time. The peak ALT here was even higher in the antischemic perfused group, but most frustrating also for the investigators, of course, that there was no reduction in the incidence of post-transplant cholangiopathy, very similar in the antischemic NMP group versus control. So basically, what Watson and also later confirmed by the Birmingham group in the UK have concluded from this is that antischemic normothermic machine perfusion is not good enough to avoid biliary complications and to reduce that IR injury of the bile ducts. So having said that, and knowing that people with the DHOPE, so the cold hypothermic, and have shown that may reduce biliary reperfusion injury, why not combine the two? Why not take the best of the two worlds, do first hypothermic, and then if you want to assess the liver function, you need to warm it up to 37 degrees. You need normothermic via controlled oxygenated rewarming. Why not combine DHOPE, core, controlled oxygenated rewarming, and NMP? So that's a study we have been, first we have been studying this in rats, and then in discarded human livers, and then finally we ended in a single center pilot study trial. The thing is, as I said, at normothermic temperature, you need an oxygen carrier. At low temperatures, you don't need it. But if you don't want to switch the perfusion fluid, if you want to have a perfusion fluid that can perfuse the liver starting at low temperature and then slowly increasing after the resuscitation phase, you can't use red blood cells, because red blood cells at very low temperature get very stiff. The lipid membrane gets very stiff. They occlude small capillaries in the liver. They even show hemolysis, and they break down, and that causes a lot of trouble in your filters, also in the pump. So we've been exploring an alternative, which was an hemoglobin-based oxygen carrier based on bovine HB. It's basically a cell-free oxygen carrier that is bovine HB that's been treated with glutaraldehyde and polymerized. So basically it's 4 or 5 HB molecules clumped together. It's a very small size. Of course, it's much smaller than an erythrocyte, so it's not easy to obstruct. It has also a very low viscosity, the fluid. It can be kept at room temperature on the shelf for many, many years, at least 3 years now. We've been using stuff that's been 3 years old. You don't have to cross-match it for blood type, for example. And it has been initially developed for in vivo application, but has never been FDA or in Europe approved for in vivo application for anemia, for example, because the half-life is very short and it tends to extravasate and go into the interstitium where it may cause nitric oxide scavenging and vasoconstriction, etc. So for in vivo application with a short half-life of 19 hours in patients with anemia, it's not very beneficial. But for ex vivo, where we usually keep the liver maybe for 12 hours ex vivo on the pump, it could be sufficient. So, and again, the main advantage is that you can use this HBOC molecule at different temperatures. So we developed this fluid. I won't go over the table, but it's in the publication, just accepted in AGT. We try to mimic human blood, actually, with respect to colloid osmotic pressure, with osmolarity. There's some parenteral nutrition in there, antibiotics, etc., insulin, anything what we think is beneficial for the liver. But the main oxygen carrier is this HBOC. So that we have been testing first in a preclinical study, and then when the results were very beneficial, we got MATC, Medical Ethical Committee approval for an in vivo study. And we've been using this protocol to select livers out of those discarded livers that are offered for transplantation but declined by all transplant centers in the country to first recondition them with the DHOPE phase, then slowly rewarm them to 37 degrees, enabling us to judge its function and viability. And we call that the DHOPE Core NMP trial or protocol. And again, the 1 hour of oxygenated perfusion at low temperature, at 10 degrees, was supposed to resuscitate the mitochondria, to restore cellular ATP, to dampen the ROS production, and then the rewarming was there to avoid the sudden change in temperature shifts with subsequent injury that can come from that. And then after the normothermic conditions are reached, we said, okay, now we can judge the function of the liver. And for viability assessment, if the liver meets those criteria, okay, then we will transplant the liver. If not, it will be secondarily declined and discarded anyway. So the viability criteria are still subjective, although there is increasing evidence that those are evidence-based and from experimental work, but also from first clinical experience. If the liver doesn't make bile, of course, is an active process, and you need ATP to generate bile. So if there's no bile production, it could either be a technical failure, that the biliary drain is malpositioned against the bile duct wall, for example, or there's leakage, whatever, in your fluid. But if I would consider that a non-functioning liver if there's no good bile production. Then if a liver, usually there's a very high lactate to start with, because we have lactate in the fluid. If it doesn't drop, if the liver doesn't metabolize lactate, that's a non-viability sign as well. The liver is very able to maintain a normal pH, but if the liver gets very acidotic on the pump, that's also a bad sign that the normal pH acidosis settlement is not very active. But that's all for the hepatocytes. For the cholangiocytes, it took us a while to find out what is good. That's the Achilles heel, of course, for DC, especially for suboptimal DCD grades. Are the cholangiocytes and the peribiliary glands, are those still viable? And we know that we went back to the physiological function of cholangiocytes by producing bicarbonate and secreting it into the bile. As I mentioned already, the original bile has a normal pH, but when bile reaches the duodenum, it has an alkalotic pH, and that's thanks to the cholangiocytes. So cholangiocytes actively contribute to bile composition, and we have seen that if bile doesn't turn alkalotic, it's a bad sign for cholangiocyte viability. But it's also preventing the cholangiocytes against secondary detergent effect of bile salts that contribute to bile duct injury. This is just a scheme showing you that the cholangiocytes via the cystic fibrosis and AE2 receptors secrete bicarbonate, but they also reabsorb glucose from bile, and normally in the extrahepatic bile, the glucose is very, very low. Just like in the kidney, where the tubular cells are reabsorbing glucose from the primary urine, the same is happening in bile. And if the bile ducts are not reabsorbing glucose from the bile, and that is, in our opinion, a bad sign. So bicarbonate secretion via those transporters, the bicarbonate umbrella I mentioned, and then the reabsorption goes via those two transporters that usually give bile a very low glucose level below 1 millimole per liter. But then you can argue, well, the cholangiocytes, you just told us that the cholangiocytes are injured anyway in a lot of livers, and that's not predicting. What about the periliary glands? Well, those glands also produce bicarbonate. They have CFTR expression, as you can see in this immunofluorescence study. So they contribute to bicarbonate and raising the bile pH as well. And again, the PBG, in our opinion, are key predictor of biliary complications, yes or not. And almost in parallel with our observations, Chris Watson in Cambridge made very similar observations in his clinical practice that if a liver on the pump is not able to produce alkalotic bile, those are the livers that later develop biliary strictures after he transplanted those livers. And now he considers this also a viability criteria and even a non-transplantability criterion for those suboptimal high-risk livers. This is the data from a histological study where we try to correlate bile pH, bile bicarbonate, and bile glucose with the degree of histological evidence. It's a preclinical study. Of course, you can't take endlessly biopsies from the bile ducts if you're going to transplant that liver, but if you are in a preclinical setting, you can. And then we had two groups, one group with severe histological injury, given here in red, and one group of about 6 livers, I think, in the minimal to moderate bile duct injury, and you see that those livers on the pump during normothermic machine perfusion, there's a huge difference, a significant difference in bile pH and bile bicarbonate, although there is some overlap. But if you will put it in an ROC curve and you look at the diagnostic accuracy of those two parameters, they actually have an area under a curve of 0.9, so a C statistic of 0.5 or 0.8, 0.9 for bicarbonate, and pH after 2 hours of normothermic machine perfusion. I think for a diagnostic test it is reasonably good. So what about glucose? Glucose, I said if it's not reabsorbed from the bile, so if glucose during machine perfusion does not drop, and we take samples from the bile every 30 minutes, I forgot to say that, and then we use it for a point of care analysis actually, that's a bad sign. Then the thing is that after reperfusion, glucose, there's huge glycolysis from the liver, so glucose will go up in the perfusion fluid anyway. So you need to correct for that, because initially glucose is very, very high. Now we look at ratio or even the delta, but either way, glucose is also a very good predictor of the degree of histological injury. So having said that, this is the trial that we just finished in October 2018. In 1.5 year time, we had 43 livers that were offered for this trial that were declined for regular transplantation by all transplant centers. A few of those we didn't have capacity. There was patients transplantations ongoing or a machine perfusion already ongoing, or in the case of a DCD donor, the patient didn't die within 2 hours, or the liver was indeed highly risk and cirrhotic or even fibrotic. So those were all discarded, and we ended up putting 17 of those livers on the pump, and 11 of the 17 met all the viability criteria, and the liver has to meet all the viability criteria in our protocol. We went ahead to transplant them, and 6 out of those 17 were discarded secondarily. And the survival, I'll come back to that in a minute, has been 100% so far of those 11 transplanted livers. Now, what about those viability criteria? Again, I said a liver has to clear lactate, but all those 17 livers, also the one that we didn't accept for transplantation, cleared lactate. This is in gray on the left side here is the dehope phase. So basically you won't expect much metabolism there. Then the controlled rewarming in light gray. And then after 2 hours, 120 minutes, the liver is warmed up to 37 degrees. Then you see a rapid decline in lactate. Almost every liver, apart from these two in red, cleared the lactate, but even there. So there's a lot of hepatocytes. So lactate clearance, I think, is not the best marker, but we have been using it so far. There is some drop in pH, especially in the livers that we secondarily declined, shown here on the right-hand side. It usually recovers either with or without extra bicarbonate that you can add to the perfusion fluid. There's one liver that we accepted for transplantation, but in retrospect, with the current knowledge, regret and would have actually rejected if we know what we know now. That's the one shown in light green. And obviously, it's not based on the hepatocyte criteria here, because the light green liver is also among the dark green livers, so not in the gray, not in the danger zone. But if you talk about the bile duct viability criteria, so bile pH, bicarbonate, and glucose, that liver hit the alkalotic pH, but then we found out that the perfusate at the same time was a bit alkalotic as well, and when we corrected that, the pH dropped. But at that time, the recipient operation had already started, and my colleague who was doing the hepatectomy said, well, there's no way I can go back now, I need to go forward. So we transplanted that liver, but in retrospect, that liver had a too low pH of the bile, although initially it was fine, and the bicarbonate actually stayed fine, and the glucose clearance was good. But if you would look then at the delta, so the difference between perfusate bicarbonate and perfusate glucose, you see a huge difference. You see the red livers that, for example, here in the middle, livers that we declined based on bile bicarbonate, and then the light green liver that we transplanted but regret that we did is actually in the danger zone here. So we now use this as a criterion instead of the full bicarbonate, the absolute bicarbonate and absolute glucose data. Going back to the original donor demographics, there's no way we could have predicted those livers that functioned from those that did not function adequately on the pump, apart from that the hepatectomy was kind of extraordinarily long for some reason, like 70 minutes for DCD graft procurement. I think that's relatively long compared to the ones that we did transplant. But we did, for those that we did transplant, have 100% graft survival so far. We have seen one patient with cholangiopathy. I'll show you the pictures in a minute. That was the one, the light green patient that we in retrospect regretted. There were 2 anastomotic strictures that were treated successfully with ESCP and stenting and have resolved since then. This is the patient with post-transplant cholangiopathy. He's shown on MSCP. It looks like there is a cast here, so I took the patient back to surgery. This is the cast that we could actually, by doing cholangioscopy intraoperatively, take out of the bile ducts. But they still look rather nasty. If you, with the cholangioscope, went into the bile ducts, basically the severely damaged epithelium is gone. I don't know how much necrosis is there and how much of the PBG and the perivascular plexus is preserved. The patient has done well since the secondary surgery and is still surviving with the first graft, and the bilirubin have come down to normal actually now, but we have to see in a few more months whether he's going to develop biliary strictures, yes or no. But that's the light green patient. So altogether, we have seen a substantial increase, because these were all livers that we would not have transplanted in the old days. In the last year, we did 73, 45 adults, 34 adults from a regular graft, and 11 of initially declined livers that were judged viable and transplantable after normoterm machine perfusion. That gave us a 20 to 30% increase in the adult population. We have not been using those livers, obviously, for pediatric, where we are more inclined to use live donors for the pediatric program. So what about normoterm machine perfusion? Well, you guys are the experts here, so I feel kind of reluctant to say much about it. The last data published, the multi-center Spanish experience in JHEP by Amelia and Tino is extraordinary, but almost no serious biliary complications. So from moving to a transplant center, maybe moving to the donor back with all the logistics and extra efforts that come with it, might be more beneficial. So we will certainly start using that as well. Basically, for those of you who are not involved in the surgical, you take over in the surgical practice. You take over the circulation of the organs after withdrawal of life support, after cardiac arrest, and after the patient is declared, and then use 1 to 2 hours to resuscitate and reoxygenate the organs before you, basically in a regular procedure, procure them and take them to your transplant center on ice in cold storage. Basically, you do the same what you do ex vivo with machine perfusion. You restore ATP levels. It allows viability testing, although I think there's not been done much research on what are good criteria to judge a liver during NRP. Again, I have no personal experience with this. The ones who do have are here in the audience, but it does result in a significant increase in the number of transplantable livers with a low rate of cholangiopathy. So to summarize, I think machine perfusion for us surgeons is a very exciting new development. It is It's a lot of work, but it's also fun to do. It gives us much better understanding of ischemia reperfusion injury in general also. There's basically two major types now: hypothermic oxygenated machine perfusion or normothermic machine preservation or perfusion if you do it antischemic, or normothermic regional perfusion if you take it back to the donor. If you talk about hypothermic machine perfusion, basically what we now understand from it, how it works, is that it helps us to help the mitochondria to restore ATP, to restore their oxygen depth, to reduce IR injury as a result of that. There's histological and first clinical evidence that it definitely helps to protect the bile ducts against reperfusion injury. It's relatively simple and safe. It can be performed in a transplant center. It takes away all the hassle and logistical challenges by taking a whole team to a transplant center or putting even a liver on the pump during transportation. I mentioned the 3 randomized controlled trials that are in progress, and hopefully we'll get the results in this year. Actually, I expect of all 3 trials. Normothermic machine perfusion, it might be more appealing because it seems to be closer to physiology. I think it's also potentially dangerous. The NRP is relatively safe if you take that to the donor hospital, and again, that's been increasingly explored. Ex situ machine perfusion, either antischemic or from donor to transplant center. I think there is evidence that yes, it can reduce IR injury, but so far the only clinically significant difference has been a reduction in serum transaminases in the recipient. You can argue whether that's a relevant endpoint, whereas antischemic normothermic machine perfusion is certainly not good enough for the bile ducts, and there has been no reduction in biliary complications with that technology. So again, that's why we think combining the two, and I think in the literature you see also more investigators now mentioning this combination, combining the best of maybe the 2 modalities, maybe a safe way not to reduce complications after regular transplantation, but more to increase the donor pool and to utilize donors that are being offered and now declined for regular transplantation and expand the number of possible transplantations. So that was my last presentation. I want to acknowledge the contribution of a large group of MD PhD students over the last few years, my colleagues in the HPB surgery department, but also in pathology, the ICU, and our dedicated OPR unit, which is shown in this picture. That's a separate OR. We have an operating facility in the OR complex of our hospital where we can simultaneously perfuse a liver, a pair of lungs, and 2 kidneys. So it's a fully modern, dedicated room, but we are very fortunate to have that. So in a large transplant center nowadays, I think this is almost a must to have, and I think there's more and more centers that are start building these facilities. Thank you again for inviting me. It's been a pleasure and honor to be here, and I'm happy to take any questions. Well, formally we don't know because the field is evolving so rapidly at the moment. At the same time, all the equipment and all the disposables are very expensive. So healthcare insurance companies and governments will probably also ask for the evidence that this is all beneficial. So for now, I think everything needs to be done in clinical trials to collect most robust data that we can get from this. Centers that have been approaching me with this question, that especially surgical groups that want to start using machine perfusion in their clinical practice, I always advise to do preclinical research first, at least with some pig livers or so, to go through your learning curve, because it can be technically challenging. And if possible, start with hypothermic machine perfusion first before you start using normothermic machine perfusion to get used with the equipment and the technical problems that can be occurring. Because in the low temperature, it's relatively safe, even if you have a technical failure with your pump. But as I said, it's going so rapidly. I hear pumps being bought by centers everywhere now in Europe and in other places in the world, and people start using them even without preclinical experience. And I'm a bit worried about this, that if something happens, and things will happen if you introduce new technology, it might give the whole new promising technology a bad reputation if people embark on this too rapidly. So I think you should have preclinical experience, or at least proctoring and help from an experienced center like Birmingham or Cambridge or Oxford before you do this. No, I think that what we definitely learned from the Nature paper from Peter Friend's group is that for a regular graft, for a regular DBD or a regular DCD graft, you don't need this. The graft survival is 93% or so, I think, in the control group in this study. And this equipment and procedures are very expensive, so you're not going to gain much there. For DCDs, I think with NRP, I would consider NRP also part of the machine perfusion studies and protocols. That already has good hope that it reduces the incidence of complications. The same is true for the ex situ. So for DCD, if centers like Spain and the UK and the Netherlands, where we have a substantial number of DCD grafts, that could be maybe becoming even a standard practice, as it is for NRP now in this country, and it will become for D-Hope, I think, in my country. But the rest will come. The rest of the benefit will come from extending, increasing the donor pool by making more livers suitable for transplantation, I think. No, it's not. It is a very important question. Actually, we just wrote and got accepted a commentary in the journal Gastroenterology, together with the group from Zurich, that this is the key thing for the future. If we want to let this new technology, which in my opinion is very promising and it will change transplantation in the next coming years, but if we want to safely expand this and explore this, we need to do it in clinical trials with clinically relevant endpoints. And serum transaminases, in my opinion and our opinion, is not a clinically relevant. It may be a secondary endpoint, but it's not a clinically important endpoint. And if we want to convince insurance companies and authorities and those who are controlling the money that they should invest in this, we need to demonstrate that it's cost effective, that it has cost effectiveness, but you also need to demonstrate that it's either increasing the number of transplantable organs or reducing clinically relevant endpoints and complications. So that's something we as a community, and especially the scientific societies, are now realizing, and we have to make sure that new protocols have clinically relevant endpoints. Yeah. No, the question is about perfusing with bile salts. Well, bile salts are very difficult to understand because there is so much literature that they are detrimental, that they are toxic, especially the hydrophobic bile salts, and that there are strategies for cells to protect themselves against the detergent effect and toxic effect of bile salts. But there's also a lot of evidence that bile salts are needed to stimulate regeneration and also normal physiological processes inside the cholangiocyte, and those are probably more the hydrophilic bile salts. To be honest, we are adding hydrophilic bile salts to our perfusion fluid based on the proliferative, protective and proliferative effects. I would not add a hydrophobic bile salt to your perfusion fluid, but it's also caloric. So a bile salt also drives bile flow. And we have noticed that the bile flow definitely increases if you add bile salts to the fluid. Otherwise, it will be only the de novo production that is driving the bile flow. And good flow, just like good urine production, of course, is also important for bile ducts to flush out the bile ducts and debris that may be present in the bile duct. So, to be honest, I don't know the final answer to that question, but yes, bile salts are important. Yeah, we need the trials, but we also need international registries, I think, to collect data from single-center experienced, uncontrolled trials. Because no way we are going to make head-to-head comparisons of all the different technology in future randomized controlled trials. We need randomized controlled trials, but for now, the control groups is always static cold storage, which is non-ethical in livers that you wouldn't dare to transplant in a regular case. So that's why we have an uncontrolled D-Hope NMP trial. But all the other techniques, I think we need good randomized controlled trials, and eventually we have to do head-to-head comparisons with the different techniques and see what is the most cost-effective, affordable, technically, logistically most affordable technique. It will probably take another 5-6 years, but we also need, and now fortunately scientific communities like the ILTS and ELITA are picking up on this. We need international registries also to collect more data to answer these questions. Yeah. Well, we have done experiments in vitro with isolated mitochondria that we isolated from hepatocytes. There is several other groups, like the group in Zurich, but also other centers that have been also using rat livers and pig livers to study this. There's even now more understanding of the mechanisms. There is a very interesting Nature paper a few years ago that has proven that accumulation of succinate, if you look at the electron transport chain inside the mitochondria, the 5 different stations where the electron has to be transferred to and ATP is generated down the road, succinate is an important substrate for complex 1. But if in the cold, if everything is slowed down, and especially when there is no oxygen, then succinate is accumulating at the level between complex 1 and complex 2. Now, once you rewarm and you give oxygen again, what happens is that the accumulation of succinate drives the electron chain in the reverse direction. So instead of transferring electrons from complex 1 to complex 2, it goes back to complex 1, and that's the complex that is generating the free radical oxygen species. That's causing the secondary lipid peroxidation, DNA damage, etc. If you can you can get rid of the succinate accumulation in the cold, it's completely abolished. In all organs, in this paper, I think it was from a Canadian-French group, nicely shown in almost every organ, if you give oxygen in the cold, you restore that suction, you avoid or you take away the succinate accumulation, you basically bring the electron chain back in the antigrade order, and that avoids the ROS production. And that's basically what you do with oxygenated hypothermic machine perfusion. We have not shown that with respect to succinate accumulation. We are in the process of analyzing our data and biopsies. But the Zurich group, I spoke to them a month ago, so Dukovsky in Zurich has already, with proteomics, has shown that, and other metabolomics has shown that indeed this is probably the mechanism how it works.
Yeah, thank you for the kind answer.
5:15, so thank you very much again for coming.